So for the next session, it's my honor to welcome Dr. Professor N.P. Singh, Senior Director, Internal Medicine, Academic Head and Chairman, Scientific Committee at Max Super Speciality Hospital, Ghaziabad. He is former Director, Professor, Head of Medicine and Head of Nephrology at Maulana Azad Medical College and Hospital, New Delhi, and Vice President of the Delhi Medical Council. The session will be moderated by Dr. Peter George.
Good afternoon, everyone. Let me introduce Dr. Pankaj Nand Choudhry, the next speaker for the topic, a 2-for-1 bargain using Cilnidipine to treat hypertension and its comorbidities. Cilnidipine is a very commonly used antihypertensive, and most of us use it on a regular basis. For want of time, I request Dr. Pankaj to start the talk.
Yeah. Thank you to Dr. Peter, and I'll start my talk, not wasting much time because we are running a little late in studio. So the topic today was given to me using Cilnidipine to treat hypertension and its comorbidities. Okay. So we all know that the hazards of suboptimal BP control. We know that most common attributable risk of death worldwide is hypertension. And we are just talking about diabetes, in many conferences, and you must be very surprised to know that the diabetes-related, deaths per year globally, it's only 1.6 million per death, right? But this hypertension is not a control; it can cause 7.6 million deaths per year. So it's very astonishing, figure, and we must know due to this, to managing this, deadly risk factor. 62% of cerebrovascular disease due to hypertension, 49% of ischemic heart disease due to hypertension. And we all know the benefits of control. Aggressive treatment reduces severe morbidity and improves survival. Effective and long-term control of BP, it is stroke by 40%, MI by 25%, and heart failure by more than 50%. So we all know that hypertension is the second leading cause of kidney failure, one being diabetes. Therefore, it is essential to keep hypertension in check. Various antihypertensives are available to manage hypertension. We all know that, and there is GNC7, GNC8 report says that there are few drugs to treat hypertension, the first line, the second line, and we all know the diuretic, calcium blockers, ACRBs are the front line medicines for hypertension, and beta blockers may be used in compelling indication. And we've been knowing that this CCBs, we've been using for decades, and the prototype of the CCBs, amlodipine, I think is one of the other prescription of hypertensive medications. Okay. Right. So the previous slide, this is the workplace of calcium blockers. This is the calcium channels. It's a very complex, molecular structure. We won't go in details, but this is alpha 1, which is the main moiety of calcium. Right, it got influx into the cells. And we have 6 types of calcium channels. We have L, N, P, Q, R, T. And for clinical significance, there are 3 channels: L type, N type, and T type. They are main target of blood pressure regulation and pharmacology treatment. L type is long-lasting, also known as DHP, that is dihydropyridine receptors. The T type is transient receptors, and N type is neural or neuronal or non-L present throughout CNS and PNS. So these are types of calcium channels and distribution. We all know that this L types of channels are there in heart and cardiac muscles, smooth muscles, skeletal muscles, and bone, and they're dominant in heart vascular muscles. There's no renal presence of L receptors in the kidney. So this is neural. This is present throughout the brain, peripheral nervous system, the brain nerve endings, and they are present in the renal tissues. And T is for transient, present throughout the kidney, adrenal gland, heart, and vascular muscles, and they are present in the kidney tissue. So we all know this calcium blockers classification. This is the old classification: the first generation, second generation, third generation, fourth generation. The prototype of first generation nifedipine. We've been using nifedipine, but because of this some issues with the side effects, it's not being used nowadays. Yes, but it is used in pregnancy at times. Second generation nicardipine. It is, this carbon norepinephrine levels and heart rate is increased in both first and second generation, and they are predominantly L type. Amlodipine, we all know we are using this molecule for since decades, right? And now the fourth generation Cilnidipine that we'll be talking about in a while. The difference that it is both Ln and type blocks both Ln type receptors, and contrary to this second third generation, which blocks only this L type. So we'll see what is the effects of blocking both L type and N type calcium blockers, calcium receptors. Okay, so just a word about Cilnidipine. It's a unique calcium channel blocker. It blocks both N and L type calcium channels. It blocks N-type channels to inhibit the release of norepinephrine at the sympathetic nerve ending, and blocks L-type to stimulate vasodilatation. So the novelty of this calcium channel blocker lies in the fact that it reduces BP using two-directional approach rather than acting on a single cause of hypertension. And you can see that this is the blood flow in the glomerular. This is one is afferent arteriole. This is efferent arteriole. And in afferent arteriole, there's both T, L, and N types are present, both all the three. And at efferent is only T type and N type channels are present, calcium channels are present. So Cilnidipine blocks L type and N type calcium channels, and L type calcium channel blockers preferentially dilate efferent arterioles. Yeah, and there is both L and T types, so L and types calcium channel blockers potentially dilate efferent and efferent arterioles both. So it means that what is the significance? So this L-type CCBs favors an increase in glomerular capillary pressure. For example, amlodipine is L-type, so it can cause increased glomerular hypertension, and that may cause a little risk of increasing more proteinuria. Whereas LN-type and LN-type and LN-T-type CCBs like Cilnidipine, it elevates glomerular hypertension by decreasing this pressure in the efferent arteriole, and this it might help in decreasing the protein secretion. So this is a diagrammatic representation of Ln dual action of Cilnidipine. You know that it blocks this L-type calcium channel, which causes vasoconstriction, and it blocks the N-type channels, which secretes norepinephrine, causes a lot of effects like vasoconstriction, then increase of cardiac contraction, increase of heart rate, and then decrease of renal blood flow through alpha-1 and renin secretion through beta-1 subunits. And Cilnidipine blocks both this. It causes vasodilation in the smooth muscle, and N-type calcium channels. It causes vasodilatation, decrease in cardiac contraction, and decrease in renal blood flow. So it would have the benefits that we'll discuss in subsequent slides. So this is the same diagram to show the Cilnidipine and the difference with other CCBs. The Cilnidipine causes a decrease in norepinephrine release, and other CCBs like amlodipine and other nifedipine, they causes increase in norepinephrine release. And they are the effects which are seen that there is no effect on heart rate and LV and diastolic pressure, the Cilnidipine, and there is increase in heart rate due to reflex tachycardia and increase in left ventricular and diastolic pressures. And stroke volume, double product, and right atrial pressure, stroke volume double product decreases, and right atrial pressure increases with use of Cilnidipine. So Cilnidipine in podocyte. So Cilnidipine has been shown to suppress development of urinary protein excretion in hypertensive patients that I have already discussed. Study shows that Cilnidipine prevents the development of proteinuria and glomerular podocyte injury. These two neuroprotective effects cannot be simply explained by the hypotensive effects of Cilnidipine, as its neuroprotective effects were greater than those of amlodipine and L-type CCBs with similar effects of blood pressure control. So it is very evident that it has got a positive effect on the renal secretion of protein. And possibly because there's a reduction of N2 reduced oxidative stress, the direct antioxidant effects in podocytes, Cilnidipine suppresses reflex sympathetic hyperactivity, and Cilnidipine suppresses RAS activation. So there are multiple factors that are there with the use of Cilnidipine. Amlodipine, yes, we'll be using amlodipine with very good results. But if you see that molecular structure of the calcium channels have been shown and its effects, so we would say that it could be an incomplete CCB. Why? And it blocks only L-type calcium channels, thus acts by peripheral vasodilation only, while it leaves the other two crucial calcium channels like this N-type and T-type in the hyperactivity state. And this is a very important study, which is AASK, which is ASK. It is African American Study of Kidney and Hypertension Study. They have actually seen the effect of this ACE inhibitors, ARBs, and calcium channel blockers on the decline of the renal function with the use of that. And only this ACE inhibitors, actually ACE and ARBs, causes less decline in renal functions, and amlodipine actually got some deterioration due to amlodipine administration, right? So it's a very important study done in 2002 to 2007, and it's a higher incidence of peripheral edema. Yes, this is a very important side effect of this amlodipine, because if you see that more than 70% of a patient would develop peripheral edema, and it may cause decrease in compliance, and the physicians actually, going for some, unnecessary investigations, ruling out kidney disease, ruling out liver disease, and ruling out heart disease. And if you stop this amlodipine and switch over to other molecules, the edema settles down. So this is an important effect of amlodipine, and what the clinical evidence is with cilnidipine. Just few slides about that. So there is excellent tolerance to cilnidipine in hypertensive to amlodipine, which is amlodipine-induced edema. There are a lot of studies are there. So I'll just elaborate one or two. The 27 patients with essential hypertension with amlodipine-induced edema, then concomitant nephropathy, cardiac failure, hepatic cirrhosis, they were all ruled out, by appropriate test. And amlodipine therapy was substituted in all the cases with an efficiency equivalent dose of cilnidipine. The study duration of 4 weeks, and these are the results. And you can see very well that the edema, decreases when we switch over patients from amlodipine to cilnidipine. So therapy with cilnidipine resulted in complete resolution of amlodipine-induced edema in all the cases without significant worsening of hypertension or tachycardia. So cilnidipine is an acceptable alternative hypertensive patients with amlodipine-induced edema. And sometimes we feel that switching over to cilnidipine won't cause decline, but there are many studies which show that switch over to cilnidipine, the edema actually subsides completely. So the another study comparison of amlodipine with cilnidipine on antihypertensive efficacy and incidence of periodema in mild to moderate hypertension individuals. The prospective study, 60 newly diagnosed hypertensive. They have two arms, amlodipine and cilnidipine arm, and they were studied for 3 months. And you can see the difference between amlodipine and cilnidipine. Almost 60% of patients got edema compared to only 6.6% with cilnidipine. So it's a very important study. And it concluded that both amlodipine and cilnidipine have shown equal efficacy in reducing blood pressure. It's not very, its efficacy is same as amlodipine. Cilnidipine being N-type and L-type calcium channel blockers associated with lower incidence of periodema compared to only L-type channel blockers blocked by amlodipine. This is another study which, shows cilnidipine versus amlodipine, this RCTs in renal disease, which is a very important Carter study. The multi-center open label study duration was 1 year, and almost 350 candidates were eligible for that, and 147 and 130 was 2 arms. And this was the results, and you can see the changes in the urinary protein creatinine ratio during the treatment period. So this is the one important factor that I was discussing. The because of dilatation of the efferent arterioles, it might decreases the protein secretion. So this study showed that SBP, that is systolic blood pressure, and diastolic blood pressure was significantly reduced in both groups. However, the urinary protein to creatinine ratio significantly decreased in the cilnidipine compared to the amlodipine group, and it's very important because most of the patients who are diabetic, have nephropathy, so it could be, the good alternative to ACE and ARBs. So cilnidipine exerted a greater antiproteinuria effect than amlodipine. The study suggests that cilnidipine is superior to amlodipine in preventing the progression of proteinuria in hypertensive patients when coupled with an angiotensin system inhibitor. Right. The other Kyoto cilnidipine study, which has an open label randomized 60 patients with CKD with well-controlled hypertension, be treated with RAS inhibitor and L-type CCB, and you can see, and after 4 weeks time, they switched over to cilnidipine group, and this was the result. You can see the change in the serum creatinine, cilnidipine 6.2 and versus amlodipine 3.32. It's a vast, huge difference with statistical significance. And this is in case change in proteinuria from baseline 12 months, 55.4% with L-type, this is amlodipine, and only this is negative, minus 15.9%. It actually reduces the proteinuria on CCB in this cilnidipine arm. So it's a very significant finding. So there is change in the heart rate of 12 months, and you can see there is no change in heart rate, and amlodipine has caused some reflex tachycardia. So they concluded that after 12 months, proteinuria and heart rate was significantly decreased in the cilnidipine group, but proteinuria increased and heart rate remained unchanged in the L-type of calcium channel blockers. Though there was significant positive correlation between the percentage changes in proteinuria and heart rate, cilnidipine has anti-hypertensive effects equivalent to those of this L-based calcium channel blockers. And in patients with CKD, proteinuria can be decreased by switching from L-CCBs to cilnidipine, thereby improving the renal function. So it's a very important study. And another study was seen in Japanese trial with anti-proteinuria effect of cilnidipine in hypertensive patients treated with RAS inhibitors. It's also a multi-center open randomized trial, duration was 48 weeks, and you can see the results. Yeah, it's there. So you can see there is mean systolic diastolic blood pressure was almost the same in cilnidipine group and amlodipine group, and this is changes in urinary protein, that is grams per day after 48 weeks, and you can see the difference. So cilnidipine is superior to amlodipine in preventing the progression of proteinuria in hypertensive patients undergoing treatment. So comparison of the effects of cilnidipine and amlodipine on ambulatory blood pressure, and this is 24 hours ambulatory BP monitoring before and after use of cilnidipine, and you can see these changes. Just to summarize this interpretation, it reduces the 24-hour daytime and nighttime BP pulse rate was significantly greater in the cilnidipine group than amlodipine group, and we all know that all stroke and hypertension or myocardial infarctions, happened in the early hours because of the systolic blood pressure surge. And cilnidipine is seen to reduce that SBP surge in the morning, and the heart rate also goes down with the morning. So antiplatelet blockers blockade by cilnidipine may not cause reflex tachycardia and may be useful for hypertensive patients in this scenario. Okay, so this is the effect of cilnidipine on heart rate and uric acid metabolism, and we know that uric acid is an important risk factor patient having hyperuricemia with hypertension. So they have seen the effect of uric acid with cilnidipine use, and it was 100 patients, amlodipine and cilnidipine 5 versus 10 milligram, and you can see the results. There's a change in the uric acid level. Definitely in cilnidipine arm, there is a decrease in the uric acid level as compared to amlodipine, and you can see the reduction in the heart rate of 24 weeks, and it is quite significant in the cilnidipine group. So cilnidipine exerts hypertensive activity similar to the L-type CCB amlodipine. Unlike amlodipine, it reduces heart rate and also improves uric acid metabolism, which is an important associate factor for patients with hypertension. Considering these features, cilnidipine is a promising drug of choice for targeting patients with hypertension and hyperuricemia, since both disorders often coexist in clinical settings. So this is also RCT with comparative effects of cilnidipine on heart rate and proteinuria, and I think with the same results, the BP blood pressure was the same in 2 arms, but there is decrease in urinary creatinine ratio with cilnidipine as compared to amlodipine. Okay. So cilnidipine, by virtue of blocking N-type channels presenting in the efferent arterioles and podocyte, decreases the glomerular pressure, thereby offering significant podocyte protection, which contributes to the antiproteinuric effect. Cilnidipine is a better alternative to amlodipine in hypertensive patients with proteinuria due to its cardioprotective and immunoprotective effects. So it is a study which shows the effect of cilnidipine on changes in heart rate and interval in QT interval dialysis. I'm not going to detail, but yes, it has shown that cilnidipine may have beneficial effects in reducing CV events resulting from increased sympathetic nervous system activity and arrhythmias in hemodialysis patients. So to summarize, the cilnidipine and renal protection, it blocks N-type calcium channels expressed in podocyte and prevents podocyte injury, offers greater reduction in proteinuria than amlodipine, thus improves renal function, exerts higher antioxidant activity than amlodipine, reduces uric acid levels significantly, offers greater renal protective effect than amlodipine. So this is the last slide. Cilnidipine blocks both N type of calcium channels, effective control of hypertension with OD doses, equal efficacy versus amlodipine with lesser side effects like period edema, better reduction in BP morning surge that we have seen in 24 ambulatory BP monitoring, negligible changes in heart rate, and it's very important in patients treating with hypertension, cardioprotective effects, that is decreased sympathetic nervous system activity, decreased reflex tachycardia, and improves LV diastolic function. Protective effects are decreased intraglomerular pressure, leading to decreased protein excretion, and it improves metabolic profile. That is causes low uric acid levels. So this is all about to say with this drug, and I think if we have questions, that I'm very pleased to answer them. Thank you very much.